So we're going to start today's lecture with a video made by the Alliance for Health Policy and Systems Research, which is one of the institutions globally that's promoting health policy and systems research. And you may recognize a few of the faces in this video.
Health systems around the world are designed to maintain health and preserve life. However, many lack the resources and support needed to treat and improve the health of people on a daily basis, let alone when pushed to their limits by major incidents. An outbreak of Zika virus in northeastern Brazil in early 2015 led to a widespread epidemic in the Americas, islands in the South Pacific, and Southeast Asia. Many of these countries saw parts of their health system overwhelmed by the epidemic, while already existing problems were highlighted. Natural disasters, from the Nepal earthquake in 2015 to the floods in Louisiana in 2016, have disrupted and in some cases destroyed health facilities and services. These events, along with the mass migration of people to Europe from the Middle East and Africa, and the growing global threat of antimicrobial resistance, are examples of situations where health systems have had to withstand and adapt to pressures. Economic crisis, the outbreak of war and conflict, and an increasing burden of NCDs and mental illness all represent challenges that require strong health systems. But what is a strong health system, and how can we build one? A health system is the collection of people, institutions and resources arranged through policy to improve the health of a population. A health system is strong and resilient when it is able to prepare and respond to crises by maintaining its core functions and adapting when needed. Strong and resilient health systems have a clear focus on ensuring equity and social justice, and support the empowerment of the most vulnerable members of society. There is a growing interest in resilient health systems from donors, agencies, and national governments. But potential strategies need to be guided by evidence from across a range of research disciplines, known together as health policy and systems research, in order to fully understand the social and political complexities of these systems.
The health system goes beyond the availability of health services. It goes beyond the mere provision of services in the facilities to look at the entire context that informs those services. It includes the health service providers as well as the healthcare seekers. It includes entire populations. To build a resilient healthcare system, you need to look into aspects of policy, you need to look into aspects of research so that you come up with things that are relevant to keep that dynamic going.
Societies are unequal, and that creates barriers, geographical, financial, clinical, cultural barriers to access to effective healthcare. As researchers, our responsibility is to find a way of understanding what are the motivations, what are the determinants of those inequalities and the different uses of power, help policymakers to address those inequalities effectively.
Most times people would want to believe that a health service is a health service, a disease is a disease. What you need is the appropriate medicine or the appropriate interventions. But if you look at even just basics, like what we have in our country, things like the essential drugs list, who determines what becomes essential? Is it the donor who is financing the budget, or is it the Minister of Health people, depending on what they see? We have to begin reviewing, looking at health systems as being beyond health services, whose wisdom is located with medical professionals.
HPSR plays a crucial role in informing the design of health policy and the delivery of interventions to protect and improve health. An essential focus of HPSR is the implementation of policy, providing practical solutions to challenges in health systems and ensuring policy research is tailored to and embedded in each health system.
The most effective way of getting health systems policy research into the policy agenda is to establish regular dialogue and interaction between the researchers and policymakers. So if the policymaker understands the research background, the researcher understands the policymaker's context, what you are likely to find is that the embedded research that will come out of that marriage is going to be much more likely to be successful in changing people's lives.
Health policy and systems research has been integral in facilitating major health system improvements in challenging environments all over the world.
really important to integrate health systems and policy research into crises and incidents when shocks happen to health systems. Otherwise we can't respond to them effectively and we can't build effective systems which are going to be more resilient into the future.
When the response to the Ebola epidemic in West Africa began in 2014, HPSR was important in helping national and international partners understand and navigate social and cultural issues that were, in part, causing the response to fail.
The Ebola Response Anthropology platform is an online and face-to-face advice service set up to bring long-term social science research and knowledge in real time to inform outbreak responses. The advice we were able to offer helped humanitarian and medical agencies to be more sensitive to community members' own concerns and anxieties, to make their messages and the ways they delivered them fit local contexts better, to deal with resistance in a way that didn't just assume communities to be ignorant. And crucially, it showed that communities were already learning and that actually it was this that was beginning to turn the epidemic around. So agencies then began to support local level behaviour change rather than to ignore it and assume it wasn't happening.
In India, a collaboration between national and international organizations carried out health policy and systems research to support and improve the implementation of India's village health committees. VHCs play a vital role within the Indian health system, connecting the most marginalized communities to the services they need, as well as monitoring the effectiveness of these services.
The Public Health Foundation of India and the National Health Systems Resources Centre, where I work, were co-collaborators on this research project. Our task was largely to make sure that the research was embedded within the national guidelines, to look at what divergences there would be from the national guidelines, and to make sure, as far as possible, implementation was within the scope of what the national guidelines was meant to be. Provision of hand-holding and mentoring to the groups and to the communities went a long way in making them more vibrant and more inclusive of the marginalized. Meetings started to happen more regularly. Committee members felt more empowered to take action on local issues.
Health Systems Global and the Alliance for Health Policy and Systems Research, as well as their members, are playing a key role in developing and advocating for this essential field of research.
Health Systems Global and the Alliance work two ways. One is to empower and arm the community of people involved in health systems work and health systems research globally with the tools and mechanisms to improve health systems. And the other way is to, through action at a global level, through close partnerships with other organizations to promote the agenda of health system strengthening and resilient health systems globally.
We are contributing to make sure that health systems have the needed evidence before these are designed. These are not designed because of somebody thinks this is the way to do it. So we are helping them to have a real knowledge base which is based on the scientific rigor.
Both the Alliance and Health Systems Global place the development of HPSR front and center in their mandates. We work continuously in improving the science of HPSR. It's a hybrid field which draws in inputs from various social sciences and public health sciences, so it's constantly evolving.
The priority for the Alliance and HPSR that we should have an adequate body of knowledge so that when there's a need to use to strengthen the health system, it's available. The other is to strengthen the capacity, especially in the young researchers and the women, so that countries, if they need the evidence there, they can use the local knowledge from their own researchers.
Like a lot of other people, I started off not as a health systems researcher. I started off as a medical doctor. Issues that I was concerned with in treating my patients were often not immediately under my control as a medical doctor, and they referred to broader systemic issues such as financing and the availability of the right people to do the right work at the right time, and also to a poor understanding of what people really need when they seek healthcare and when they're poor. Discipline that or the sort of subfield that really helps to address these issues is health systems research, and that's how I became passionate about it, and it's I haven't looked back.
Health policy and systems research is crucial to building stronger, more resilient health systems. It provides us with essential knowledge to guide our pursuit of the Sustainable Development Goals and to achieve universal health coverage. Only by generating a robust evidence base can we design and implement policies and plans to ensure health systems are able to prevent and treat illness and respond and adapt to future shocks.
Right, so that's who we are, health policy and systems researchers. And what I'm going to be doing now is just tell you a little bit more about this field. Actually, is what is health policy and systems research. And, you know, it's not going to be stuff that you don't already know in some way or another. It's how we bring together different ways of thinking to bear on the problems and issues of health systems. Okay. So what I'm going to do is talk a little bit about this field that really has evolved in the last 10 years or so. How we define health policy and systems research, what its scope and nature is, and yesterday I said we've got fuzzy boundaries, so expect fuzzy boundaries, okay? It's not a tightly delineated field with very tight definitions, but some attempt at explaining what this field does, its scope and its nature, and then also look at examples at macro, micro, and meso levels, and then something about the methodological considerations. And then we'll ask those who read the article to present one application of health policy and systems research from someone who studied here, okay, did this course. Okay, so in the year 2000, WHO put out a very significant report. That really started a global conversation around the field of health policy and systems research. There were lots of people doing it. I mean, ever since health systems have been around, there have been people researching those systems, trying to describe it. There were some quite famous typologies that, you know, when I entered the field, we spoke about. But in an organized fashion at a global level, it really started around 2000 with that report. In 2004, there was quite an important meeting in Mexico when people got together where they actually said we need to research health systems. And that really coincided with the era of the Millennium Development Goals, where huge amounts of resources were mobilized for looking at the disease burdens of the South. So where I come from, in the African continent, there was a catastrophic HIV epidemic that had unfolded over the 90s, the late 80s and 90s, which got global attention. And what you got is the mobilization of resources to deal particularly with the HIV epidemic, the establishment of the Global Fund, for example, the emergence of a number of very significant international players who were thinking about suddenly refocusing attention on what was happening in the global South. And tuberculosis, malaria also, and quite significant global targets set, including, for example, around maternal child health, the growing awareness of the problem of maternal mortality, all of that leading to a resurgence of interest in how to tackle those big health problems affecting the global South. And what you had was a proliferation of interventions, of donors, of people from the global North, and the discipline of global health was invented at that time, really. Numerous programs being set up, interventions being developed, all sorts of trials being instituted to look at ways of addressing these disease burdens, lots of money going into it, and then a sudden realization that it was almost impossible to scale up these programs, that no one had looked at how all of these new interventions were going to become accessible to all in an equitable way. And then suddenly everyone realized there's something called a health system, okay? The health system is the vehicle through which effective interventions are delivered. And that realization led to suddenly an interest. People shifted their gaze towards looking at what is that system. It started off by a recognition that unless you had sufficient health workers at the base, you couldn't deliver these interventions. People started to look then at drug supplies, the availability of commodities at the coalface, And then people started to think about how money was flowing through the system. So all of that led to then, if you like, the development of the idea of building blocks. And then people said, but, you know, you need to lead a system. And actually, the only people who can lead health systems are the people of those countries. It can't be led by international agencies, USAID, Bill and Melinda Gates Foundation, as much as they were putting resources into those systems, unless the country players were steering, guiding, deciding, then actually all of those resources would be spent, but probably quite badly, and there were big issues of sustainability in all of those systems. So then the notion of governance and leadership, okay, and that is more recent and has become much more prominent now as we talk about the Sustainable Development Goals, and where concepts such as universal health coverage are now trying to bring together all of these ideas. So all of that, those realizations were happening there in Mexico, where ministers from different countries were coming together and saying, hang on, we need to look at this thing called a health system. And then a research community obviously linked to that, saying, well, what does it mean to be researching, generating evidence on health systems? So most people in the past said it's a black box, it's politics, okay? It's too complex, it's too difficult to understand, and it's too complex and difficult to try and influence. And that's where a body of researchers started to say, but hang on, it is worth trying to generate evidence in this area. Let's try and at least describe what these health systems are doing and the extent to which they're able to deliver on all of these new entitlements that were being implemented in health systems. And so you then get in 2008 those people coming together again in Bamako, which is in Mali, Bamako in Mali, coming together again and making then the first call to action for health, for research on health systems. And then you had all of these global players, WHO, the Alliance for Health Policy and Systems Research, which, by the way, has been around for 20 years. So they've been plugging away at this for quite a long time. And I think in your readings is the 20th anniversary report of the Alliance, okay? And you had then the first global symposium on health systems research in Montreux, and then every 2 years after that. So in 2012 it was in Beijing, and then the Society, Health Systems Global, was formed, which is a space for health systems researchers and policymakers to come together. And that is the society that Kabir Sheikh now chairs. All right. And you had also then the launch of the WHO strategy on health policy and systems research, which is one of the readings that's also in your pack. And then we hosted in Cape Town the Health Systems Global in 2014, and then last year it was in Vancouver. So that's been the evolution of this field. And in that 20-year report of the Alliance for Health Policy and Systems Research, what it documents then is a very rapid growth in publications in this field. So it's becoming a more established scientific field in public health, in health more generally. And a lot of those publications coming from low and middle income countries. So an increasing proportion, so capacity is being developed. And you noticed in the video South Africa, India, Argentina, okay, featuring there. So that policymaker in South Africa is someone I work with very closely, and my colleagues, Keith Clutie. India, there's quite a powerful collection of players here. Argentina is also a middle-income country. So a lot of the innovation in this field is being driven by the middle-income countries, actually. By the BRICS collective, China's also got a very significant place. So they're, in a sense, driving the initiatives in this area in a whole lot of ways. And there's tons of stuff being published in international journals from India, actually. And, you know, it wasn't difficult to find articles, actually, to discuss in these lectures. So it's a growing field, and a lot more people are coming into it. In our courses, when I started teaching in Cape Town, the first track in health policy and systems research, the students were quite skeptical, and not many wanted to do it. It's now one of the most popular tracks in our MPHs in our region. All right, so that's a little bit of the background. This is the WHO monograph. It's called Changing Mindsets. And I don't know, this is a painter, Escher. I don't know if you know it. It's like, can you see the fish turning to birds? Yeah, it's quite amazing, isn't it? Yeah. So that's what it is. It's about different ways of thinking, new ways of thinking. And thinking about health policy and systems research as the GPS of decision making in health systems, providing navigational support to decision maker, locating the starting point for the health journey, the desired destination, and options for getting there. So health policy and systems research as something that needs to be embedded in country and national health systems, as something that requires an interface between researchers and policymakers and implementers within country contexts. And so that is the notion of embedded research. And, you know, we can talk about that because I and you and most people in the research community were brought up to understand that research must be completely independent of politics and decision making. And this, now we're trying, that's part of the changing mindset. And how one navigates that relationship, how you as a researcher are able to sustain your independence and continue to provide a critical mirror is one of the key dynamics of that relationship. So we're going to talk more about that in the last lecture, about the meanings of embedded research and what it means to have a national identity as a researcher. So the other thing we're all brought up to value is having an international profile as researchers, okay? We value, in South Africa, all the research promotion and ratings ask, do you have an international reputation? Are you regarded as an international figure? And that's also one of the dynamics one has to navigate in this field, is how do you remain nationally relevant, but also how do you engender international conversations? All right, so here's the definition, one of the definitions from the Alliance. Health policy and systems research is an emerging field that seeks to understand and improve how societies organize themselves. So that's a generic way of thinking about a health system, is just how the society organizes itself to achieve collective health goals, and how different actors interact in the policy and implementation processes to contribute to policy outcomes. So that is the policy side, if you like, of health policy and systems research. And there were lots of behind-the-scenes conversations when that WHO report was being developed about whether you call it health systems research or whether you call it health policy and systems research. And in the end, the combined approach won. Okay, so health policy and systems research is quite interested in describing how a health system works. That flock of birds, that complex flock of birds, that complex adaptive system needs a lot of description. Okay, we need to get a handle on what is going on there and how do we, from lots of different lenses. And so we value descriptive work quite a lot in the field because we don't know about the basic everyday functioning of a health system, and every context is different. So we're interested in thick descriptions, if you like, of our health systems. And that is also one of the mindset shifts, in that we don't have to rush to doing the intervention trials, which is what epidemiology values, okay? And a lot of internationally also, what's valued in health research is intervention research, going in there and doing stuff. rather than just standing back and saying, what is there? So research on describing a system, how it works, but also we're interested in how a system changes, okay? Both just watching how it changes. So if you've got the implementation of village health committees, National Health Rural Mission, RSBY, whatever, watching, trying to evaluate what's happening as it unfolds, what are its impacts, evaluating policy and policy implementation, but also thinking about how to change it. Okay. So also doing intervention work. So what health systems are and how they operate, what needs to be done to strengthen health systems in order to improve performance, how to influence policy agendas, how to develop and implement such actions in ways that enhance their chances of achieving performance goals. And that's where the relationships with policymakers become quite significant. All right, so what is the scope and nature? What do we look at in health systems then if we want to do all of those things? Well, we'd look at the building blocks. Okay, we would research health workforce issues, supply chain management, financing of health systems. We could also look at the goals like access, coverage, quality. We could look at the link between those and outcomes. We could also look at initiatives to strengthen or reform health systems. And, you know, there is a field called program evaluation. Have you had lectures in program evaluation? Not yet. And they will? Okay. So there's quite a strong link, and it's, you know, some people might call what I do health policy and systems research. Some of it, other people would call it program evaluation. So there's overlap between different fields and approaches. So it would be, for example, a program evaluation of an initiative to increase access to vaccines, let's say. You could approach that from a health policy and systems research lens and evaluate that initiative. And that might also be called a program evaluation. Implementation research you would have heard of, or implementation science. You would have heard of operations or operational research. So all of those are areas that overlap. They're not exactly the same, but there will be overlap in the ways of doing things. And in that chapter, so that chapter that's in your reading was a chapter that was written for a textbook of epidemiology, actually. So it was for people who come from an epidemiological background, explaining all of these concepts and terminologies and how they relate to each other. Health policy is, so that's the other side of it. Health policy concerned with the what, so what is being defined as policy. But health policy research is not just what's in those documents at the state or the federal level. It's very centrally also about what happens when you try and implement it. Okay, what happens on the ground. And so a large part of health policy research is interested in policy implementation, the how. And then there's a field of health policy analysis, which I believe you've been exposed to, which is interested which takes a strong focus on the actors. Remember I said that health systems are people systems, and they're people with different levels of power and interest in that system. So we're going to be looking on Monday at a stakeholder analysis that is a typical methodology used in policy analysis to understand questions of power, interest, and influence. Okay? So we're interested in actors, their relationships and processes in implementation. So that's just another way, that's a diagrammatic representation of what I've just said. On the one side, you've got health systems, okay? And yesterday I showed you that figure, software, hardware, you got it? Okay, and you looked at it, it's in that framework. So we're interested in the structure, organization, technology, resourcing, but we're also interested in what's called the software. We're interested in the people, actors, relationships, values, and then on the other side, we're interested in health policy, contents and instruments, so what's being done to change all of that, and how that is influenced by actors, power and politics, institutions, interests and ideas. So that's what the field of health policy looks at. And all of that is concerned with policy change and health systems development in the context, in a global and national context. So that is what the field does. Okay. So one way of understanding what a field is by saying what it is not. Okay. And so HPSR is not clinical research. It's not basic science. So we're not interested in the best treatment regimes for tuberculosis or hypertension or diabetes, in testing those, even though we think that's very important research. We're obviously not, we don't sit in laboratories, okay, so that's quite clear. But we're also not focused on what epidemiology does best, okay, which is disease distribution, causes, interventions. So we wouldn't primarily be interested in NCD risk factor epidemiology. Even as I say, we regard that as very important. We wouldn't necessarily be doing intervention studies to look at health promotion interventions to address risk factors for NCDs, exercise, diet, whatever, smoking. That's not our expertise. But we do recognize health promotion as being incredibly important. And so we'd be much more interested in how do you organize systematically at scale in a way that is equitable and universal, a health promotion initiative, okay, that addresses maybe NCDs but also maybe other things as well, maternal, child health, diarrhea, that would have principles of health promotion applied to all. Or how do you ensure chronic lifelong follow-up of people with chronic lifelong conditions, whether it's infectious or non-communicable. HIV, TB is not lifelong, but it's similar principles. Diabetes, hypertension. What is it about the quality of a frontline health service that ensures continuity of care and enables trust between users and providers, so, and is accessible and affordable, so that people are able to attend it regularly without incurring inconveniences. So that's what we'd be interested in, is the vehicle through which effective interventions are delivered. And that's quite important because quite a lot of people who do programmatic research, like looking at interventions to support breastfeeding, might, and if they're looking at elements of the health system, that's not necessarily HPSR. Okay, the HPSR, we're interested in that generic structure. We may, however, and we often use disease programs as tracers. So in the webinar at 11 o'clock, I'm going to be talking about a program of work we did on equity and access. And there we used disease tracers. We looked at tuberculosis, maternal health, and ART, HIV. Because actually we needed to hone in on something. A health system is so complex that one needs to focus on one thing to try and understand the whole. So we quite often do look at specific diseases, but often as what we regard as an indicator or tracer of a broader phenomenon. So for example, the impact of district strengthening on child health outcomes or maternal mortality. Or they may be researched because they have system-wide effects. So South Africa, out of a population of 55 million, 6 million or so have HIV. Okay? That's about 10%, 11% of a population have a life-threatening illness. And so we have a universal program of access to antiretrovirals, 3.5 million people on treatment. Now that sounds nothing in your terms, I know. But it's one of the biggest programs in the world, if not the biggest. And in our little health system, making that possible required quite substantial reorganizations at multiple levels. It didn't happen overnight, but it did happen fairly fast. Retention in care is quite significant in that program. It does much better than TB. Well, TB we're getting better at, but diabetes and NCDs. So what is it about the system reorganizations that happened around HIV that it hasn't happened around NCDs? So we're quite interested in those kinds of questions. But we don't start from a disease focus. We're not disease specialists. And we recognize that that is important, and there are people who need to have that identity and orientation. But our approach is slightly different. So I showed you this slide yesterday, that a system is a very large and complex entity, and we break it down by looking at macro, meso, and micro. Okay, and we think of our research along those kinds of lines. So just to recap, the macro would be the system as a whole, trying to comment on it and make some judgments on it. Obviously, there's huge questions of attribution and causality we have to try and get our heads around, and plausibility. But that's one thing that people try and do. Or at a meso level, trying to understand the organization and the factors at, say, a hospital, a unit, a district. Why does one hospital do so much better than another in the same jurisdiction? Trying to answer those kinds of questions. The local cultures and systems of service delivery that are very influenced by those kinds of factors. So that would be a more meso level, so reconstructing that smaller system, or we may look at very particular relationships, like the relationships, typically patient-provider, community health system, provider-manager, or manager-policymaker, or senior manager. All right, so those relationships, and then also country-international. So those may be some of the relationships, and within that, some individual relationships. So between the executive and the political layer, how the politics defines what the bureaucrats do. So we're interested, that would be more micro level. So here are some of the, I've just defined that. So here are some examples of research at each of those different levels. At a macro level, so there in 2011, a book, and there was a paper in the Lancet, Good Health at Low Cost, 25 years on. Have you heard about this? Okay. So in 1980 something, or was it late 70s? 25 years? Yeah, it was the 80s. There was a first report, so it says 25 years on. 25 years before, the Rockefeller Foundation put out a very influential monograph called Good Health at Low Cost. And have you seen that? You should, there must be one in your archives somewhere. It's because it's Kerala, Costa Rica. So Kerala, so it was, Kerala was there, okay? Costa Rica, Cuba, I think China was one, and there was a fifth one, Sri Lanka, I think, yeah. So those 5 players were considered to be the positive deviants doing much better than the average across the globe. And when I trained in public health in the late 80s, early 90s, we all read that very closely. So Kerala, we knew about Kerala a long time ago, and other people wrote about Kerala as well, as a much better performer relative to the resources available than many other countries. So then in 25 years later, that study was repeated. Okay? And these are the case studies that were examined. Thailand, which has done exceptionally well, is one of the global good performers. Bangladesh, Ethiopia, Kyrgyzstan, Tamil Nadu. So your neighbor got in this time. And I think Kerala could have been there, but because it had been described previously. But so those were regarded as positive deviants. And what this research project did is it brought together a whole lot of players, like country researchers, people from Chennai, where does Mura Leaderin work? Yeah, so there were researchers from the countries and policymakers and international researchers who got together with each country, and they did a macro analysis of what had happened in those countries. So, you know, you can look at outcomes like you would look at, for example, life expectancy as quite a key outcome, and so you could compare countries with respect to life expectancy, and you see that some do much better than others, and so then going backwards and saying, well, what is it? So they then looked over very long periods of time at health systems development, starting, you know, maybe 20 years back, and then looking over time at all the different interventions, using multiple methods, okay, so from different perspectives, trying to understand what was happening, looking in particular at trends in HR and financing, those as possibly the most critical inputs to health systems, but also analysis of policy actors and processes. So, for example, you can have changing political terms. You can have quite a high turnover of parties, of people in power, but if all of them support the basic same trajectory and don't each time try and interrupt it, okay, then that is a very powerful force for development. If it's going in the right direction at the start, and that it retains a grip and you can move forward, then that's one of the ingredients of success. So continuity in ideas, in policy, and to some extent in the people steering those ideas was quite a significant factor here. But also it was the priority placed on health. It was the organization of civil society. So continuity is established through political pressure, and that is absolutely key. That, you know, the organization, if the broader society, if the citizens are demanding that there's better health, the chances of it happening are much higher, particularly if they've got a political voice. So that's what that study did, and it's freely available on the web. There are lots of videos. There's a book, there's a Lancet article. It's really interesting reading, and I strongly recommend if you're interested in that. But also from a methodological point of view, how they went about it. So they did use the WHO building blocks. It did provide some kind of starting point, but they went way beyond that. And a large part of it was getting researchers from different perspectives to look at this complex system. So, you know, each of you here had your own theory about a health system, okay? And so that's what you have to recognize, is that people, in looking at a complex system, will look at it differently. So in research methodologies, particularly macro level, the notion of getting lots of different actor perspectives is quite key. And then even from a research point of view, people from disciplinary perspectives, approaching questions in different ways. And it's in that transdisciplinary interaction that you begin to be able to grapple with some of the macro questions. So that's what that project did. Here's an example of a Mezzo level research project. So don't worry about the details. But this was done in 2008, and it's a study in Zambia that was documenting supply chain for antiretrovirals in that country. And remember, I told you there was a flurry of resources going for the HIV epidemic, okay, hitting all of these African countries. Everyone became concerned, all right? And so, you know, money and drugs and things started being pumped into all of these countries. And what you had was anarchy in some ways. There was chaos actually on the ground. So this study was documenting the antiretroviral supply chain system, so one of those building blocks in Zambia as a consequence of this new global policy initiative. All right? And what you've got here is the funding for the drugs, the implementation agency, the procurement, the storage and distribution, and the service delivery. Okay, so the service delivery, it's all the same facilities. Everyone was targeting the same facilities. You've got hospitals and you've got frontline health facilities. Those people relate to, I think I counted 19 different players above them, just to deliver one drug. Okay, 19 players. Clinton HIV Initiatives, Global Fund, Government of Zambia, USAID, PEPFAR, other donors, CDC, UNICEF, Philips, Crown Agents, and then the medical stores, big research initiatives, CIDERS, the Church Health, all of those 19 different agencies that people at the front line are sitting on top of them so that they can deliver this one service. With 19 different reporting systems, 19 different information things you have to fill in every time you give out that drug. So that had a clear advocacy role to try and say, hang on, this is not going to work. And it provoked a whole lot of discussion. So, you know, there was something called the 3 1s. One agency, one reporting system, one country mechanism, etc. In an attempt to establish some kind of integration of processes. Because as the district manager trying to coordinate all of that, you can't. There's simply, it goes beyond the capacity to coordinate. So describing, this is a descriptive study at a Mezzo level. Tackling a particular research problem that people identified at the coalface. So they went back and then they tried to trace all of the different pathways that were happening. And you could do the same around here, around the multiple vertical interventions hitting frontline providers, around specific issues, and how they have to prioritize or make decisions at the coalface between all of these different things hitting them. Okay, so then an example of micro level. So this is the relationship between health workers and supervisors. A study in Ghana, West Africa. So you can't see that either. Sorry about that. But what you've got here is an assessment of health worker productivity. Okay. So here you've got the midwife, community health worker, and health extension worker. And what these different box plots is, you've got, this is the percentage here, direct patient contact time, 20%. Documentation, remember I said of all those things, forms you have to fill in? Okay. I think that's the median. Okay, so more than direct patient care, about 30%. Staff development, okay, a small percent. And this one is personal time. Doing nothing, okay. Well, drinking tea, maybe absent. So 40% personal time. And for the health extension worker, it becomes half the time. Right? So this study, they did time and motion. They went and looked at how time is being used. They observed facilities. That's one of the standard methodologies people might use to try and look at productivity. Right? So low productivity in health facilities. Descriptive work. But then they looked at then the relationship between that and the role of supervision. That was, the study was trying to understand that. And actually the productivity levels were 1.5 times greater if visited by a supervisor in the last month. And in fact, nearly 2.5 times higher if the supervisor was perceived as supportive. Right. So that's an example of a micro-level study that we would do in the health system. Okay, understanding people, relationships, performance, productivity, and also, okay, supervisor perceived as supportive. What is that view of human beings? Our three-point typology of, yeah, is it the economic actor? Yeah. Yeah, it's the social. Maybe this part is the machine perspective, compliance. So they're coming. But actually, if you understand the social perspective as well, it's even better. Okay. So those are examples of macro, meso, and micro health policy and systems research. And the readings work with different examples at different levels. Okay. All right, so then I've spoken about loads of different kinds of studies here. What are the methodologies? So as I've said, it's in applied discipline. So we're interested in the problem or the topic. So if it's supervision and we want to document work productivity, for sure we'll use quantitative methods to do that. We may also have a qualitative component to that. If we're interested in the quality of leadership by ministers of health, we're going to have to forego doing an intervention study on that, because no one controls who appoints ministers of health. We can't say, I'm going to appoint a good minister in this state and a bad minister in that, and I'm going to see what happens with health systems. So we would start with the problem and then think the methodology. Supply chain, for sure, they couldn't design one questionnaire. They had to, it was like investigative journalism. They had to go and find out and talk to lots of people, and then they reconstructed that diagram. Okay. They might have had some questionnaires or checklists, but they probably used a range of methods to construct that story, that picture. So we start with the problem or topic rather than the method or discipline. And so we're eclectic from a disciplinary point of view. They can be qualitative or quantitative. Often we use mixed methods, and often we use what some people refer to as bricolage. Okay, bricolage is a French word for cut and paste. Or bricolage is like you put pieces together. Yeah. Like you do a mosaic and you use different kinds of things. Often we're multi-method. Okay, we won't mind looking at documents. We won't mind looking at historical archives. We don't mind looking at record reviews, analyzing routine data, doing surveys, doing in-depth interviews, doing ethnographic observations. Okay, so just watching and seeing what happens. So that's the approach, and we're quite multidisciplinary. So come from management sciences, anthropology, psychology, economics, public health, epidemiology. We bring that together. Increasingly, and that's quite interesting, is that people may come from a discipline and then become health policy and systems researchers, but increasingly there are people who start off saying, I'm a health policy and systems researcher, without necessarily coming from one single discipline. Okay. But disciplinary depth is important, actually. If you're going to do a survey, you want someone who really is trained in epidemiology or in quantitative methods. So you need to have the expertise around the table. And we're also quite interested in how to grapple with complexity. Okay. How do we understand a system as involving multiple interacting forces, involving lots of different agents, in complex feedback loops. And that's what Joe Varghese' article tries to do, is using some of the contemporary methodologies for trying to grapple with that. So it's when you've got numerous interacting elements, open systems influenced by lots of things, it's not a closed system. The investigator has little control over the events. You're working with large units, a district, a hospital, and it's very heterogeneous and context specific. So the dynamics of immunization coverage in Kerala is very different to Bihar, and in fact within districts within Kerala it's very different. And that actually we're talking fundamentally about social phenomenon, about people, their interactions, groups, professions, cultures, and that is something one has to grapple with in this field. So that was an example of trying to grapple with complexity, which we saw yesterday. And that we're going to talk about. So that is ways, causal loop diagrams, systems dynamic modeling, so ways of doing that quite systematically. And because there's no single methodological approach, we don't have one gold standard like the randomized controlled trial, and that's quite important. So I was trained in public health epidemiology. Think of study design in a stepwise way. You start with descriptive, analytic, case control, cohort, quasi-experimental, experimental. That was very clear. The randomized controlled trial was the gold standard, and that is how you get published in the high impact journals, is if you do that kind of research. And actually, we treat study design as flat, okay, non-hierarchically. We value all study designs equally because we understand that in this kind of research, one standard is not going to give you the answers. So there's a range of study designs or research strategies we use. Regular cross-sectional studies, longitudinal, we'll do experimental studies, and case study. We're going to talk a lot more about case study tomorrow as one of the core methodologies that a lot of us use a lot. Ethnographic research, action research, and we incorporate a range of epistemologies. Have you had an input on epistemology, the philosophy of research? Yeah. What constitutes truth? Have you encountered that term, epistemology?
Yes, PhDs have, not the MPhs.
Yeah. Okay, so it's ways of viewing the world. Yeah. Yeah. So a lot of the things we're looking at in health systems are quite invisible. All right. Trust between providers and patients is an invisible thing. It's hard to measure it. Well, there are tools and constructs that get at it, but it's not like, is the drug there or not? Or it's not a biological measure. Has the blood pressure improved? The blood glucose gone down? It's direct observation is quite difficult. Okay, you have to get at it indirectly. And there are research traditions, the positivist research traditions, that says unless you can put a measuring stick to it, beat it with a measuring stick, don't bother going there, all right? And so in health systems, because we recognize that a lot of what we're interested in is not visible, different kinds of paradigms are also quite important. So we're incorporate a range of different paradigms actually in the field. Even though most of us would tend to have an orientation that is not restricted to positivism. We may use the methods of positivism and value them, but most of us would then have moved beyond that as a way of viewing the world. So having said that, bricolage, open, lots of approaches, perhaps a little bit all over the place, it doesn't mean that one doesn't approach the research endeavor in a systematic way. And this is probably the most important slide, that the research endeavor is still a systematic approach to investigation. So you still have to be very clear what your question is and what the problem is that you're investigating, and you need to develop a research process that is rigorous and defendable. So we would follow the same steps, and in the health policy and systems research courses that I teach, we take people through this process, okay, of developing an HPSR protocol that clearly identifies the research focus and questions, has a design that is entirely defendable, that ensures research quality and rigor, and that applies ethical principles. So if you want to read more about all of the approach to the field, different examples, the macro, meso, micro, the different kinds of study designs, I strongly recommend this methodology reader, which I think is on your reading list, but I don't know that I put it in the pack. I can put it in the Dropbox. It's freely available on the internet as open access. And then there's a lot of material on the Alliance for Health Policy and Systems Research website, if you're interested in more. So that's what I have done my lecture, and I'm going to now hand over to the presenters of an example of health policy and systems research that grapples with complexity from here.